So everybody brought their kids. It was pretty fun. All right, is that everybody? We good? Anybody missing? Oh yeah, and it's just right there. That's, yeah.
Really cool one. Yeah. I love the second year's guy. We were talking about it. What's happening?
Yeah. No, I was just you're not. I feel fine.
Huh?
I feel fine.
Oh, that's not good.
Yeah.
That's good. Apparently sleeping earlier. And sleeping later. Also, there's a lot of very
Say it again.
So like you like first sleep, right? First night you do a lot out of bed. Yeah, you try to recover. Just start sleeping earlier. Like sleeping longer earlier in the day doesn't feel as refreshing as just sleeping earlier. Like I'm really into it.
Yeah. No.
Oh, did you do that walker?
No.
It's got the signs.
Basically told me everything that I knew, like that I already knew.
Yeah. I like to read about like military stuff, and that's why they like good. Where's that?
Fiance is doing medicine in Ohio State.
Alright.
Next 3 years.
Ohio State. Oh, I think I drove past it. Columbus. Yeah, it's a nice city. I like it.
No, we did not plan it like for
It's okay.
3 years for him. Yeah, he's just
Yeah.
he hasn't had to call this marriage. They do like different clinic. This one.
Oh no, I haven't read that one.
No, I think it's outside.
Oh yeah, the other guy was a good shape.
I saw it. That's the one with Matthew Potter, obviously.
Yeah, Matthew Potter.
All right. Well, why don't we get started? The rest of the crew can kind of trickle in. So we're just going to roll through a few cases. I want you to think about the patients. Think about how you would get them to sleep safely, what method you would use, and we'll chat about it. So, start out with a 63-year-old male, history of poorly controlled diabetes, hypertension, COPD, coming in for an XLAP, suspected bowel perforation. He has an NG tube in place with active bilious drainage. Those are his vitals. What do you guys think about this patient? What jumps out at you?
Which what?
What jumps out at you about this guy? Okay.
Emergent surgery.
So emergent surgery. Stuff coming out of his tube. Pressure's a little soft. Hi, guys. Oh no, it's okay. It's hot out there. Sorry?
Likely some kidney disease.
Likely some kidney disease, creatinine's a little elevated, heart rate's a little elevated, it's febrile,
Blood count.
it's got a white count. So what are all these things maybe suggestive of?
Septic.
Okay, yeah, all right. So he's maybe a little septic, maybe his kidneys aren't great. So what kind of monitors would you use for this guy? We're going to kind of treat this like the beginning of an oral board stem. What would you want in this guy before you went to sleep? Standard ASA monitors. What are standard ASA monitors?
EKG, pulse ox, internal CO2, temperature,
Okay.
and non-invasive blood pressure.
Would you guys put an A line in this guy before you got him to sleep?
Yeah.
Okay. Before you put him to sleep?
No, after.
Okay. That's kind of. You could go either way. I mean, it kind of depends on how much time you have to talk to these guys, how emergent this is. Sometimes especially a guy with type 2 diabetes that's poorly controlled, that has some renal insufficiency that you didn't even really know about. COPD, maybe the guy had a silent MI. Maybe his heart function's not great. Maybe his exercise tolerance is poor. Maybe this is somebody you're going to worry about a little autonomic dysfunction. Maybe they're not going to react very well to induction. I will say most of the time you see a patient like this come in, your attending is not going to be excited about putting an A-line in pre-induction unless you have another reason to do it, which kind of leads us to the next part of our discussion of, okay, so you're not getting beat-to-beat blood pressure, so now you have to be really careful about what you give this guy to get him off to sleep because you want to avoid all the things that you're worried about. So what kind of induction technique would you guys use for this guy? How would you put him to sleep? We can go back. Okay, rapid sequence intubation. Do you worry about his kidney disease? Using something like succinylcholine?
His potassium's not too high.
Yeah, and that's really the point. So depolarizing muscle relaxants in the absence of something that would upregulate those extrajunctional receptors. As long as your potassium's fine, it's fine. We put to sleep. I actually put a kidney transplant recipient to sleep today. With a potassium of 4.5 and a creatinine of like 4. So you're only going to push that up half to 1 milliequivalent. Shouldn't be a dangerous level, and likely they're living a lot higher most of the time anyway. So yeah, succinylcholine is totally safe. What kind of induction agent will you use on this guy?
You like Special K, so.
Okay, I like ketamine.
Might go with etomidate.
So what's the concern with etomidate in a guy like this? So you know that he's... Yeah, especially in septic patients. So this guy's like kind of borderline, maybe septic shock. Probably going to get a lot sicker before he gets better. You see this a lot. These surgical patients, they come in, they have a problem, and the first thing that happens is these surgeons go reading around, and they get a lot sicker before they get better. So thinking in the context of his overall hospital stay, certainly from a hemodynamic standpoint, etomidate would be a great choice, but maybe not the best thing for him long term. So yeah, you could use a little bit of ketamine. Could you use anything else?
It's already tachycardic, so you're going to worry about his hemodynamic. I mean, if you take that sympathetic drive away, you're going into kind of tank, especially if you're going to have Narline or something. Maybe not propofol or...
Could you use propofol?
Yeah.
Yeah, you really can. There's no right answer. This is a guy that you could put to sleep with propofol. I'd probably chase that propofol with a couple cc's of phenylephrine. Maybe have a little Feder, maybe have a little vasopressin lying around, just in case he's on an ARB that you don't know about. Diabetic guy with some renal dysfunction, high likelihood of being on an ACE or an ARB. Not going to be real responsive to phenylephrine, so something to think about. But you certainly can. It's going to kick in a lot faster than ketamine. You can also mix and match. You give them a little ketamine. Maybe you reduce your dose of propofol a little bit so you're not seeing quite the same degree of hemodynamic instability. That's one of my preferred ways of putting people to sleep is I'll give them a lot of ketamine. I'll give them kind of a finishing dose of propofol just to make everybody comfortable when their eyes are closed so it looks like they're asleep, and then you can kind of continue. All right. Would you take any special precautions? We talked about rapid sequence induction. I would definitely have that NG tube on suction while you're putting this guy to sleep. Certainly think about, hemodynamic compromise and the idea that, especially, with his blood pressure already a little soft, guy has a history of hypertension. You don't see hypotension until people are really, really sick. So he's already tachycardic, he's already tachypnic, he's already febrile, and he's hypertensive at baseline. So yeah, he's going to bottom out pretty fast. You want to make sure you have everything you need to get him off to sleep. And he's set 98% on 4 liters, so he's probably not going to have great reserve once you put him to sleep, although people with COPD do hang around a little bit longer. Any questions about this guy?
Would you run this case with a central line later, after you sleep, or would you put an A-line out? We talked about A-line, but would you do a central line?
So for this guy, I would probably start out with a couple of big IVs and sort of see where we go. This is really when talking to your surgeon comes into play. It's something, and we talked about this a little bit the other day. I don't think we're great about teaching our residents to communicate with our surgical colleagues. I think a lot of times, cardiac surgery, liver transplant, there's a lot of conversation with the surgeons because you really want to keep those lines open. It's okay to ask a general surgeon, hey, what do you think about this? What's our suspicion for bowel perforation? How sick do you guys think this is? Did you guys see an abscess on CT scan? Do you think this guy is going to need pressors afterwards? I would say to do this case, especially because it's an XLAP, so you're going to have the arms, you should be able to see your IVs. You need to run pressors. You worry a little less about an extravasation event that's going to be potentially catastrophic. But if you talk to the surgeon, you say, do you think is this guy going to go to the ICU? Do you think he's going to need pressors afterwards? Does he have any other indication? Is this a guy that, this is really nasty and we're not going to feed him for 10 days and we're going to need TPN? The OR is a great place to put in a central line for them. But that's a great question. Part of it also goes into the urgency. If you can do it with a couple IVs and put a central line in after the fact, maybe once they're done, you get through the case safely, but you want to put it in under anesthesia under more ideal conditions than putting it in the ICU. Certainly, none of my ICU colleagues would fault you for putting in a central line before bringing the patient back upstairs. All right, next case, 79-year-old female with a history of severe aortic stenosis, atrial fibrillation on Coumadin, hypertension, and CHF with mildly reduced ejection fraction, presenting for upper GI endoscopy for a bleed. Maybe a little early for that.
Sounds scary. What's her EF?
45. Bad enough that she needs an urgent upper GI endoscopy. Bad enough that the GI docs are willing to scope this patient. So that's pretty bad. Let's take a look. No vital signs.
Can we just sedate her? Or can we just...
You can. You certainly can. What's the downside to sedating anyone? Awareness. What else? For this particular procedure, what would you worry about?
You got a big tube down her throat.
Okay, so she's going to be stimulating. What are you worried about with stimulation in a patient like this?
The hemodynamics.
Oh, heaving and ripping a bleeding more?
It's really a possibility, although we do sedate for a lot of upper GI endoscopies. Any of her comorbidities that you might be concerned about? Excessive sympathetic drive, CHF, and absolutely aortic stenosis. Anytime you see severe AS, you got to be really worried. So what's the problem with aortic stenosis? Let me put this a different way. What are your hemodynamic goals in a patient with aortic stenosis? Heart rate, high, low, normal.
Heart rate's high.
Yeah, low. Yeah, you want to shoot kind of low, normal. Okay. Blood pressure, high, low, normal. Okay, if you were going to go one direction or the other, would you go high or low? Probably want to push a little bit higher. Yeah. So the idea is you want to allow time for the coronaries to fill, so you want some more diastolic time. You want to decrease myocardial oxygen demand, and you want to raise your diastolic blood pressure so you're perfusing. So RV perfuses in what? What phase of cardiac cycle? Yeah, both systole and diastole. LV just in diastole. But the RV is going to be very sensitive to any changes in perfusion, and certainly if you bag the RV in somebody with AS, they're dead. Okay, so say you are going to go to sleep. What would you think about? What are your considerations?
Minimize hemodynamic changes.
Okay, minimize hemodynamic changes.
Some lidocaine esmolol with propofol.
Yeah, esmolol is a great idea. Is there a pressor that's great for aortic stenosis? One in particular? Phenylephrine is great for aortic stenosis. Slows your heart rate down, jacks up your afterload. It's probably what phenylephrine is best for. We use it for drops in SVR that we assume are related to too much anesthesia, kind of this isolated vasodilatory phase. But really, AS, great time to use phenylephrine. What are your other considerations? What else are you worried about in this patient as far as getting her off to sleep? Your GI tract is empty? You think your stomach's empty? No, it's probably full of blood. Yeah, that's no good. So what would you guys think about doing? Okay, another RSI. So what would you use? What do you guys think?
Reduction.
Ketamine also seems reasonable. A little bit of tachycardia.
Mm-hmm.
But if you use esmolol,
Yeah, you could offset it with a little esmolol if you wanted, but yeah, ketamine would be great. Anything else good for hemodynamics?
This would be an atomic case.
This would absolutely be an etomidate case. You could absolutely use etomidate for this. Remember with etomidate that you don't blunt a lot of the sympathetic response. So you do have to be a little bit careful about those patients getting tachycardic, especially with direct laryngoscopy. So yeah, esmolol would be a great thing to have on hand. Try to blunt her response early, get a little fentanyl in her, get her a little more comfortable. Any other considerations in a patient like this? Anything else you would want before you got her off to sleep? Any monitors you might want to use? Yeah, I would actually probably put an ALI in this patient. AS scares me. So what happens if this patient codes? What do you think your chances are of getting this patient back if they code on induction? Why?
because with your compressions, you have to overcome the stenotic area of the aorta. So
Exactly.
you have to generate a lot of.
So your ability to actually generate flow across a severely stenotic valve, even with good chest compressions, is poor. So if this patient goes down, you're going to be in a lot of trouble. Anything else you might want to put on this patient before you put him off to sleep?
Definitely have 2 large bore IVs.
Okay, good access, absolutely.
Some blood on hand.
Have some blood on hand, that's a great idea. Anything else that you could place on the patient before you put him off to sleep?
I mean, check what EKG leads.
EKG leads.
Have standard monitors.
Okay, got standard monitor. Anything else?
Flow chart.
Oh, T. Yes,
You can do a flow track. We'll talk about non-invasive cardiac monitoring another time.
Okay.
I'm not a huge fan, but I'm sort of biased. I'd probably put pads on this patient too. So somebody with a history of AFib with RVR, who's actively bleeding, who's in extremis, you put that patient to sleep, they go into RVR, they're probably dead. But if you have pads on them, you can do a synchronized cardioversion, you can pop them out, and you've got a much better chance of getting them back. So something to think about. You don't have to do it on everybody, but just remember, all right, our job is really to worry. Our job is to worry about patients, so surgeons don't have to. So they can focus on their task at hand, and we can control their hemodynamics. We can keep them comfortable. We can do everything that needs to be done so they can get these procedures done safely. Pads would certainly be a very conservative measure, but it would be something I would think about in something like this.
Where are the pads in OR?
They're on the code card. So there's a code card in every core. If you ask the nurses,
They're not in the OR.
they will go get it. No, but it's right outside the door.
Okay.
So right inside the pod. It's really easy to spot. They'll bring it in. They'll help you put them on. It's a nice way to signal to the surgeons how sick a patient is sometimes. Especially the endoscopists. And I'm not trying to speak poorly of our endoscopists. They do a lot of procedures every day. It's hard for them to know everything about every patient. And a lot of times, especially in a consult like this, they may not be getting a full story. But it will raise some eyebrows and maybe prompt some conversation. So sometimes it's a nice way to signal, hey, this patient's really sick. And so we need to be very cautious about how we manage that. All right, 33-year-old male at the VA, history of chronic back pain, on some long-acting opioids, has PTSD, coming in for an L1 through L4 posterior spinal fusion. He takes a pretty decent dose of MS-Contin, 10 of Oxy Q4, which he takes like it's scheduled, and gabapentin. What do you guys think?
Be sure to give them multimodal.
Excellent. Yeah, multimodal therapy, give him some Tylenol, make sure he gets his gabapentin.
Calculate his daily dose in terms of morphine IV equivalents per hour.
Absolutely. So make sure that he's at least getting placed. Make sure that he took his MS-Contin this morning, because a lot of patients will come in and they're on these crazy doses, and they say, oh yeah, somebody called me and, we went through my medications and I just didn't take anything this morning because I didn't want to take something that I wasn't supposed to take, and I figured you guys would sort it out for me. So you'd be surprised how many people are like so on top of their pain regimen and do such a great job at home who come in who haven't taken any of their pain medications in the morning. So make sure at the very least that they've taken what they take at home. What do you guys think about induction for this patient? What kind of agents would you be thinking about? What might be useful?
I would do a couple different ones.
Okay.
Like a combo with ketamine, because that's supposed to reduce your.
Okay.
Yeah.
So that is the downside to ketamine.
Strong.
He's going to be pretty strong when he wakes up. That's not to say that you couldn't use ketamine. It's not to say that you can run an infusion, but you do have to kind of keep that in the back of your mind. You got to worry about your dosing, and certainly you have to pay attention to, if you're doing intermittent dosing, how close you are to closing, when you need to stop giving that, or if you're giving an infusion, be very mindful of when you start running into problems.
I'd probably do like a pretty standard induction with propofol, but maybe have a lidocaine infusion in the background to kind of do ketamine on.
Yeah, lidocaine would be great. I'm going to caution against the use of the phrase standard induction.
Yeah, Tammy's saying that.
I would use propofol.
And oral board examiners hate that.
Yeah.
We've been taught to dislike that, because if you say that in front of an oral board examiner.
I'm going to strike it from the group. Our little handout. It's like standard versus something like that.
Just take it away.
Generic.
1 second.
Fill in the blank.
Hey, Scott.
Yeah. Example.
Yeah.
Medium. It's a medium induction.
What's the what?
Maybe very spicy.
No, you're working off of their screen. So it's like all web based. It's not ideal.
Yeah. One choice.
You can, but you need to bring your own stuff. And even then it's going to be less than ideal. Hey, let me call you back. I'm actually in the middle of my lecture. Anyway, that's Dr. Volo. He's trying to figure out our AV capabilities. He must have a really exciting presentation for you. All right, so a little bit of propofol, lidocaine infusion is a great idea. Maybe a little ketamine, plus minus. You can kind of get an idea for his PTSD, but you do have to be a little concerned, especially over at the VA, about using something like that. Any other long-acting opioids that you could use? You used a lot of anything longer acting than that?
Do like methadone or
Yeah,
something.
you can do methadone. You can do IV methadone. Yeah. So at WashU, our anesthesiologists would give a dose of methadone before they did sternotomy, and these patients woke up beautifully. It was incredible. It's starting to. You're going to start seeing it around here a little bit more, especially in people who are on lots of long-acting, take a lot of opioids at home. A lot of the acute pain people are going to be pretty excited about giving fairly decent doses of IV methadone up front, just to lay down a nice base, and then kind of treat on top of that.
Can I just jog your head real quick? I'm sorry. We are when you're thinking about giving gas, that has nothing to do with opiates. Like do you think of them as exclusive, right? Like their original pain tolerance versus they're under gas. Like they're completely.
I mean, there is synergism, but it's more thinking about what they're going to look like when they wake up.
Okay.
So, and this is less of a debate than it used to be, but there was a lot of conversation over, if we can block people's sympathetic drive under anesthesia. So if I take a guy like this, I'm like, man, that guy's on a lot of opioids. Man, it's just going to be a lot of work to figure out how much what his morphine equivalents are at home. I'm just going to run an Esmol infusion and just kind of see how he does. And then once he starts breathing, I'll titrate in some opioid. But this is something that people do. There was one attending at the VA in particular who's no longer there, but he was fantastic. But he was like 100% under the impression like, no, you block sympathetic stimulation and then you treat their pain as they move towards emergence. I don't think you're going to find a lot of people that are on that same page, but it's certainly an interesting question to pose.
Anything there on gas in the meantime, is that what you're saying?
If I understand your question correctly, it's thinking about pain tolerance of like, yes, they get this much morphine when they're awake, but if you add the synergistic effects of the gas, wouldn't they, in theory, require less opioid?
Is that it's almost like you're deconstructing it and
right.
Like thinking about which output, and then you're just titrating to each individual component versus you're just chasing with the same modality.
Right. Yeah, I mean, I would kind of look at it as, you can treat symptoms or you can treat underlying cause. And again, thinking about these patients in the context of their overall state, what are they going to look like when they wake up? Anything that you can do to minimize issues up front, decrease irritability in nerve fibers, things of that nature, potentially beneficial down the line. But it's a great question.
I also have like a sort of off-topic question, but in patients who are taking lots of opioids at home, when we talk about their like post-op nausea vomiting risk, giving them more opioids, they probably won't respond with nausea because they're tolerant, or is that not?
That's a great question. I don't know that I have a great answer for you. I wouldn't worry, I guess, as much about those types of issues. What's this guy's so I'm going to ask an off-topic question. What's this guy's risk for post-operative nausea and vomiting?
Does he smoke?
Yes.
Like 0, pretty much.
Yeah. So whenever I try to remember, like, who are the people who are like really prone to post-op nausea and vomiting, I think like the opposite of a VA patient.
Yeah.
Because I think like older male smokers, like not having gynecologic procedures. No, we don't do a lot or like strabismus surgeries. All right. 42-year-old female, history of cervical cancer, extreme anxiety, well-controlled reflux, coming in for a laparoscopic hysterectomy. 2 nurses have already attempted IV placement unsuccessfully, and she is refusing to allow any more attempts until a physician comes and sees her. Specifically, one of our CA1s who hasn't put in like 3 IVs ever as compared to the nurse that's been doing it for 30 years. This is my least favorite call in the morning because it's always like 7:25. And they're like, yeah, we couldn't get an IV in that lady and she's freaking out. And now we need you to come and take... Like, I don't like getting this call. And I remember being a resident and really not liking that. So what could you do?
The DAS right now.
Okay, you give her a little Versed. How are you going to give her that Versed? PO. How much PO Versed do you have to give an adult to actually see some efficacy? No.
10 milligrams.
You have to give like massive doses because the bioavailability of midazolam PO is significantly different than IV. It would be like a pint glass. You could give her PO ketamine, but she's going to start freaking out and like spitting at you.
Are you guys allowed to order beers at this hospital?
Like Haldol? I don't know.
So so tell me about the NPO issues with giving a patient a beer before you take her back for hysterectomy. Are you going to tell Dr. Connell, hey, the good news is we got an IV in that patient. The bad news is we got to wait at least 2 hours.
And then by the time the beers were out.
Yeah, and then it wore off and she's gonna be real pissed.
PO out of it.
You PO Ativan. Okay.
Like literally it's an epic order.
What else could you do?
Is there any IM agents?
You have ketamine IM. You Haldol IM, but that's probably a little overkill, and she's really going to be unhappy about that. What else could you do?
You could talk to her.
You could talk to her, charm her.
Thank you for being the human.
Yeah. A little sublingual Cyprex. Anything else? What else could you do? You just take her back to the LR?
Yeah, I guess.
That's one thing.
Do a little nitrous. Get a little analgesia from that. Try to calm her down. Is she going to tolerate a mask on her face super well? Probably not, but you could try. You could give her a big, depending on her airway, she's got well-controlled reflex. I'd probably investigate that a little bit more. But this could be a patient you could do a mask induction on, or at least enough to get an IV in her. You get a little vasodilation from your volatile agent anyway. I've done this many times.
I gave a patient Versed yesterday that was already slightly anxious, and it made her really tearful and emotional.
That can certainly happen.
It's like, this isn't working.
People who cry after a few too many beers, maybe similar effects with Versed. If you get, really.
Don't worry, this is a normal response.
It's okay. It's okay. So yeah, you could take her back, you can mask her down, you can get an IV in her. I probably wouldn't go so far as to do a full mask induction, but you can definitely get people comfortable on a little bit of nitrous and a little bit of SIVO, certainly comfortable enough to pop an IV in. Most of the time, and keep in mind this is a cancer patient. These people have been stuck a bunch of times. If they've had chemotherapy before, they may not have a lot of great veins left. So you're really going to want to do everything you can to optimize that. Any other question? Yeah.
So when you do the nitrous before putting the IV in, are you just doing like a full inhalational induction, or do you just kind of get them?
So if you're just doing nitrous, 50-50 nitrous hair combo usually works pretty well. I'll usually bleed in a little bit of SIVO and just say, hey, this is going to smell kind of bad, but it generally calms them down. It's usually a 2-person induction. You want somebody who's up, who's talking to them. Be very reassuring, saying this is normal, this is what this is going to feel like, this is what we're worried about, this is what we're working on. And that's going to go a long way. And then have somebody else, poking away. All right. I think this is our last case. 57-year-old male, end-stage renal disease, hypertension, well-controlled diabetes this time. Presenting from the medical ICU for a pericardial window for a uremic pericardial effusion. What do you guys worry about? Tamponade. Okay. Yeah. How do you manage that? What are your hemodynamic goals when you're managing tamponade?
You want to keep the heart rate fast.
Okay.
Slow.
Okay.
You want to make sure there's good preload so they're
Okay.
Good preloaders don't super high afterwards.
Okay. Actually, you want to run there after. So fast, full, and tight. That's kind of a way to think about tamponade.
Say that again. What's the tight part?
Fast, full, and tight. SVR. So high afterload. All right. What's the issue when you put somebody with tamponade on positive pressure ventilation?
You can restrict the preload.
Okay. What else do you do with positive pressure ventilation? So you drop preload. What happens to afterload?
Increase.
Then you drop it.
Oh, you do?
Yeah, you drop your afterload with positive pressure as well. So we're not going to love that. So you put a tube in somebody who's tamponade, and they could die. So what might be something you could do for this patient? You're not going to really do this under sedation. It's a pericardial window. This is going to hurt. Couldn't get a cardiologist to put a needle in it, unfortunately. That's a hard ask.
You do a awake fiber optic?
You could do an awake fiber optic. What do you do once the tube's in? Put them on the vent?
Could you keep them breathing spontaneously?
Yeah. You don't have to give them positive pressure. You can crank the SIVO up. As long as they're breathing okay, they're doing fine. I would definitely have a surgeon scrubbed in. So typically with these patients, this is like please prep the area, please be ready to rock and roll as we do this. You can do an awake fiber. You can do a sleep fiber as long as they're still breathing. Get that tube in, keep them breathing spontaneously, get them to a point where they're hemodynamically stable. Have all of your hemodynamic medication available. Monitors on this patient, anything you might want before you go to sleep? Yeah, probably put an arterial line. You think this patient has an arterial line coming down from the NICU? There's no way. They might have a bunch of pokes.
Yeah, well, I mean, it's in the CIC, but we have one to monitor for pulses.
Yeah. Well, this is medical ICU. Even the CICU. I send patients to the CICU. It's dicey sometimes. But yeah, spontaneous ventilation. So what would you think about in this patient? How would you do an awake fiber optic intubation?
Lidocaine locally.
Okay. So you can do blocks.
Like laryngeal nerve block.
Okay. Do a little sphenopalatine. You can do if you want to do nasotracheal. What else? What would you use for pharmacologically outside of? But absolutely, always think about regional adjuvants. Any case, you should think about regional interaction. Anything else? What would you give this patient trying to get him off to sleep? Or at least comfortable enough for an awake fiber? You give him a little ketamine. What might you want to give him before you give him ketamine? You give him a little Versed. You want to be a little careful because you worry a little bit. Like we talked about this morning. Midazolam, pretty good as far as not impairing your respiratory compromise unless you start giving them anything else. Anything to counteract one of the side effects of ketamine? Which one of the side effects of ketamine?
Tachycardia.
Okay. Anything that's going to be hard for an awake fiber optic intubation?
Oh, glycopyrrolate.
Yeah, so you give a little glycopyrrolate. So you can give an antipsychotic to dry them up. Have a benefit of a little tachycardia on top, so kind of a twofer there. You give them a little ketamine. Anything else?
They're going to be pretty rigid.
Okay.
So, but I mean, they're not going to be out enough to give them a paralytic, are they?
I wouldn't give them a paralytic because then you have to go on positive pressure, right?
Right.
Okay. So you got your local, definitely topicalized. Everybody kind of does these differently. Everybody has their own style. I like to do a little bit of viscous or the gel lidocaine, the lollipop. Anybody ever done that? You take a tongue depressor, just plop a bunch of that gel on, put it upside down on their tongue, come back every couple minutes, just pushing a little bit farther, a little bit farther. Say it's okay to swallow it. You swallow it, it's fine. And eventually, you should be able to tap their oropharynx without them gagging. So that's going to help. You can do lidocaine nebulizer. Put a little 4% lidocaine in a nebulizer. Have them take nice, big, deep breaths. You want to do that as you're going back to the OR because that's not going to hang around very long. You're going to numb up reasonably well there. There's also a side port on your bronchoscope. So once you get to the cords, you can actually drip. And this is how our ENT surgeons actually do it. They'll just take a small syringe, a little bit of lidocaine, drip it on the cords until they're nice and relaxed and open. Yeah. I love awake fiber optic intubation. It's a lot of fun if you do it the right way. All right. Oh, one more. Maybe a couple more. 26-year-old male, no known past medical history, comes to the ER after an MBA. He is obtunded, he has a C-collar, he has no imaging, and he is beginning to obstruct. I have no vital signs for you.
So difficult airway pathway.
Okay, so you have to worry about difficult airway. What else are you worried about? Worried about C-spine. What else are you worried about? Aspiration, absolutely. So he's full stomach. He has no neck mobility. He's obtunded. Not a great start. He's already beginning to obstruct. Anything else?
Cranial pressure, he's got some kind of
You got to worry about ICP. Yeah. So you worry about the things you don't know about, right? So he's got a mechanism. You can figure, more about how severe was this? Was there scarring on the windshield? How big of a deal was it? The fact that he's obtunded is certainly concerning. So does he have an intracranial injury? Is he just incredibly anemic because he's bleeding somewhere and he's, starting to drift off a little bit? Is he hypercapnic? Does he have pulmonary issues? Does he have contusions? Does he have an effusion? There are a million things to worry about on patients who are in MVC. So this, again, so important. Talk to your surgeon. What are you guys worried about? What are we doing? Or if you're down in the ER, because sometimes they are going to call you, and generally, at least at this institution, if they call you down to the ER for an intubation, they have already tried. Unless it is an airway that is known to be difficult, or they look at this patient and they're very uncomfortable, hereditary angioedema, previous trachs, things like that. You're not going to be dealing with an ideal airway when you go down to the ER here. Same way at Denver Health. You are going to go places where anesthesia gets called routinely for any intubation in the ER, and that's not the ED's right of first refusal. But at least here, just to know what you're walking into. If you're doing an airway in the ER, something has gone badly. All right. Well, how would you guys think about getting this guy off to sleep? If you can find it, go nuts.
Would that be great for him?
Thiopentol? I don't know. Maybe he has an underlying history of porphyria. It'd be terrible.
He has a much more likely
We don't know.
ICP than he does porphyria.
Okay. What else did you give him? Also, can you get thiopentol in the United States? No. What do you guys think?
Does he need anything?
That's a great question. Because you're going to go to a lot of airways where people are going to say, what do you want? And you're like, I don't know. Not much. You could probably give this guy a couple milligrams of Versed, and that would be enough to at least make you comfortable enough that you can put a tube in. Now he's 26. He's coming in after an MVA. It's 2 o'clock in the morning. Maybe he likes to party. Maybe he's got a little meth on board. Maybe he's got, I don't know. I have some friends that work in the ER, and I hear about a different drug every week. It's like these crazy, I don't know, the kids. But yeah, sometimes they don't need much, and everybody's going to be all fired up to, give them 20 of etomidate, give them some propofol, give them whatever. They might not need it. This might be somebody that you could think about, topicalizing it in. Now, he's obtunded, so he's probably not going in a great direction, but you want to make sure, like you said, think about your difficult airway pathway. Do you have what you need to get an airway in safely in this guy? Do you have a video scope? Do you have a bronch available if you need it? Do you have somebody who's willing to put a hole in this guy's neck? Right, and the capability, most importantly. What are you going to do with this? So say you say, I'm going to give this guy some etomidate or a little bit of Versed. I'm going to give him a little paralytic. We're just going to go. What are you going to do with this C-collar? You going to leave it on? Do you have to?
You got somebody like do neck support.
Yeah, you can do inline stabilization. So you can take the C-collar off. This is generally what we do. We take the C-collar off when we have somebody do inline stabilization because it's going to free you up a little bit. And you can manipulate a little bit, but you do have to be a little bit careful. These are fun. You'll do some of this at DG. And probably here in the next couple of years. All right, that's it. Does anybody have any questions? Okay, enjoy your afternoon.
Thanks.
Thank you. Yeah, it took forever to get the robot started. Huh? Oh, thanks. You guys climbing or hiking? Oh, climbing. Hiking anywhere. The only reason I